All right, well, welcome everybody. My name is Janice Fern. I'm one of the clinical ethicists here at Michigan Medicine, and I'm excited today to present the work that some of our students have done specific to the consult service here at Michigan. Well, I'm going to introduce each of our speakers at the beginning, and then they'll go in order of their introductions. We're going to save questions to the end, but as you're listening to the different presentations, if a question does come in mind, please enter it into the question and answer, and I'll make sure that gets voiced at the end while we're having that question period. All right, I know as I'm sitting here looking out a window, doesn't look like snow yet, but I'm not sure where we're all coming from or where we'll all have to go to. So thanks for joining us on this potentially blustery day. All right, so last announcement here before we get into introductions, but please sign in if you're a social worker and want CEU credit through the question and answer function, or you can scan the QR code for CME credit. All right, thank you. So quick introductions to our panel today. Our first presenter is Hannah Fagan. She's a fourth-year medical student who's applying into family medicine, and she completed the predoctoral clinical ethics fellowship this January and now meets all the American Society for Bioethics and Humanities requirements for the healthcare ethics consultation certification. Hannah is going to be discussing outpatient ethics consultation in the pediatric setting. Our second panelist is Samantha Lyons, and she's a fourth-year medical student as well, who's applying into family medicine. Sammy's been part of the Ethics Path of Excellence and actively engaged in clinical ethics consultation throughout her medical school career. She's also meets American Society for Bioethics and Humanities requirements for the healthcare ethics consultation certification. And Sammy's presentation is titled "In the Liminal Space: Differences in Reason for Consult Between Adult and Pediatric Care Settings for Patients Aged 18 to 26 years old." Our final panelist is Yana Kang. Yana is a fourth-year medical student on her research year and is anticipating applying into otolaryngology next year. She has 3 years of experience working at a maximum security prison in Auburn, New York, and Yana is going to be presenting findings from a review of clinical ethics consultation for the incarcerated population at Michigan Medicine. Please join me in welcoming Hannah as our first panelist. And the rest of us will have our cameras off while she's presenting.
Well, thank you for having me. Very excited to be presenting this on behalf of myself and John, my co-fellow. We did this work with the excellent help of Janice Fern. So we're going to be talking for a few minutes about outpatient ethics consultation in the pediatric setting. So as a brief introduction, ethics consultation at Michigan Medicine is available to anyone, any healthcare provider, patient, family member, inpatient, or outpatient. There's 3 main ways to place a consult. You can directly page the on-call ethicist by finding them through the paging site. You can call the operator and request that they page the on-call ethicist, or you can place an order in MyChart for inpatients. And most clinical ethics consultation is done for inpatients in general. There is some evidence that having an automatic order set in your EMR can increase accessibility of ethics consultations and as a result, increase the number of consultations. Outpatient care in general is where most people access most of their medical care, though there's very little written about it in the ethics literature space. So a little bit of background literature to have in mind. A 2015 study of 102 pediatric ethics consults was the largest to date at the time, and it included a review of 15 outpatient consults, though it did not separately talk about the nature of the outpatient consults separate from the inpatient consults. A 2021 study from U of M, which is 122 ethics consults for inpatients specifically, found that the primary ethical issues were goals of care in 36% of cases and futility in 11% of cases. So those were the issues that clinicians were most concerned about that led them to request help from an ethicist. So for this study, we decided to manually screen all of the clinical ethics consultations from this 2016 to 22 period to identify those that related to outpatient care specifically. We were interested in looking at the outpatient consults, partially because my co-fellow and I are both going into primary care, and we're just interested in seeing what's going on in that space. So we collected demographic data for each patient using the EMR, and then for each consult that we identified, we used a standardized schema the other presenters will also talk about. It helped us to identify the primary ethical issue in each case. So that's just one ethical issue per case. And then the relevant contextual features, there can be several for each case. 2 separate reviewers coded each of these cases. We were not blinded to each other's responses. And then we met to resolve any discrepancies and decide what was the final determination. So in total, we looked at 1,033 consults from this time period. On the adult side, we found that 19% of them were for an outpatient person. And out of 214 pediatric consults, 22% were outpatient, for a total of 44 unique patients. So there were 4 patients who had consults done for them twice. At this point in the project, we began with the pediatric data, realistically because it was a smaller data set and it was easier to start with. So I'll present quickly some of the results that we found from the pediatric data set. So these are the demographics of the patients who had outpatient ethics consults requested for them. Nothing too remarkable here, fairly reflective of the Michigan medicine patient population. Again, some further demographics. Interesting here, we have a list of who was requesting consultations for the patients. Only one of these 48 consults was requested by the family. The remaining 47 were requested by the team. So at 19 of them were requested from a hem-onc team. A lot of them had to do with bone marrow transplants. 4 related to kidney transplants, 3 from genetics, 3 from neurology, 3 from palliative care, 2 from psychiatry. And then on the right here, we have all of these teams who requested only 1 consult over the period from 2016 to 2022. I've bolded family medicine and general pediatrics because those represent the primary care specialties in this space. So you'll see that only 2 consults from all of those years were for outpatient pediatric primary care issues. These were the determinations that we made for the primary ethical issues that were relevant to each case. So for 42% of these consults, the primary issue related to beneficence and best interest concern and the staff or family obligation to promote that. So essentially, people were trying to do the right thing, the best thing for their patient. 23% related to refusal of recommended treatment. And that's a combination of patient refusal and parent refusal, because in this case, these are children. Patient preference or assent, 10%, a smaller group. So that's specifically about whether the child was on board with the plan there. 8% relating to transplants, 4% relating to truth-telling, same amount relating to confidentiality and privacy. If I recall, those specifically related to reaching out to external members of the patient's family who had some stake in the healthcare issue that was going on, but who were not directly the patient. And then these other ones were smaller groups. So DNA or code status, schools of care, the things that we think about as big inpatient ethics issues are less common here. In terms of contextual issues, 58% of them had to do with a dispute or conflict between the staff and the family in terms of their communication. 52% of them had something to do with legal systems or legality of plans, care, things like that. 40% had to do with quality of life concerns for the patient. And as I mentioned, you could have multiple contextual issues relate to one case, so these add up to far more than 100%, but you see in about half of cases, one of those 3 was relevant, or multiple of those 3. So we have a lot of data here and a short amount of time to talk with each other. So I'm just going to focus on 2 findings and what those might mean for us and for future research studies. So one finding that we had is outpatient clinicians request consultation for different reasons than their inpatient peers. So as I mentioned, for outpatient pediatric consults, we found that 42% of consults were relating to beneficence and best interest concern. For inpatient data that we reviewed for the 2021 study I cited earlier, that was only 7% of cases. And for outpatient cases, we found 23% had something to do with the refusal of recommended treatment. And for inpatient data, again, only 7% for that one as well. So there's different ethical issues going on in these spaces, which makes sense. We might consider more life or death, high acuity situations to be going on inpatient, specifically in ICUs, which are the spaces that are most typically associated with clinical ethics concerns. So things for us to consider is a specialized body of knowledge needed for ethics consultants assisting with outpatient issues, considering they're dealing with different issues there, and they might need specific advice that's grounded in a body of a body of evidence about outpatient concerns. On the flip side, are specialized resources required for outpatient specialty and primary care for both training and point of care tools. The second finding here is that primary care providers seldom request ethics consultation for their pediatric patients. We had only 2 over the course of 7 years. And we don't know why this is the case. There could be a lot of reasons. Is it because they don't need help? Maybe they don't have a lot of ethical concerns. I would doubt that, but it might be possible. Maybe things are just very simple in primary care. Maybe it's because these clinicians are just extremely competent and they don't need our help to resolve these issues because they know what they're doing, they're used to these things, and they don't feel that they need an outside resource. Perhaps there are ethical concerns and they do need help, but they don't realize help is available. We're not as present in the outpatient space. We don't have as many ongoing relationships with outpatient providers and clinics. And it's possible that, out of sight, out of mind, they don't know that we're available to them. Or perhaps the barriers to access are too high. Maybe they need help and they know help is available, but they don't feel able to request that help. So one thing that we are doing to try to reduce those barriers is coming up with an easier way for outpatient clinicians to request ethics assistance. As it is right now, they don't have an easy way to just place an order the way inpatient providers do. When you're on the inpatient side, you can just set an order, forget about it, and you know that within a short period of time, an ethics person is going to get back to you and they're going to start working on this case. For outpatient clinicians, that you have to call or page and make direct contact. So we're working on a system that should be in place by later this spring to allow clinicians to order ethics consultations for their outpatients using the in-basket system. The ethics faculty will be in a pool, and all members of the pool will receive these in-basket messages when they log into MyChart. And this should create an easier way for outpatient clinicians to request those ethics consults and might lead to sort of better relations between outpatient clinicians and ethics and better collaboration. And that's all I have for you today, short but sweet, and thank you for listening.
Thanks, Hannah. I think look forward to hearing questions later. So Hannah's going to stop sharing, and then Sammy is going to take our next.
Just getting my slides prepared as I only have one monitor. Alrighty. Hi, everyone. My name is Samantha, or Sammy Lyons, and I'm a 4th-year medical student at the University of Michigan Medical School. My pronouns are she, her, and hers. And for those listening in who may not be able to see me, I'm a white woman with thin gold-rimmed glasses and dark brown hair in a bun, wearing a black turtleneck and a gray suit jacket. The co-authors for this project are Dr. George Freya, Dr. Kelly Matula, and Dr. Janice Fern. Dr. Freya is currently a first-year fellow in allergy and immunology here at Michigan Medicine. Dr. Kelly Matula recently completed a research fellowship at the James M. Anderson Center for Health Systems Excellence at Cincinnati Children's Hospital Medical Center. And Dr. Janice Fern is the primary clinical ethicist for the Clinical Ethics Service at Michigan Medicine. And I want to extend my deepest thanks to her for her continued creative support of my ethics learning. To begin, neither I or my fellow authors have any financial interests or other relationships that could be considered a conflict of interest. During this presentation, I will review the learning objectives and background on the liminal space for patients between the ages of 18 to 26 years of age. I will then discuss how ethics consults for these patients have differed at our institution, before closing with suggestions for future ethics consults, my contact information, and an opportunity for questions at the end of the final student presentation during this bioethics grand rounds. So the first learning objective is to describe the complexity of ethical issues during the transition of medical care from childhood to adulthood. The second objective is to identify ethical concerns and how they may differ in the same patient population, depending on which service is caring for them, adult or pediatric. And the final objective is to reflect upon our institution's ethics consultation service and how we can improve bridging this particular patient population in question more smoothly and safely. So the liminal space between childhood and adulthood is distinctive for medical care, as decision-making authority shifts from the guardian to the young adult, and the patient's responsibility shifts from assent to consent. As a reminder, assent refers to the patient's agreement to participate in care, with the final authorization of the parent or guardian, while consent is given by the patient once they turn 18 years of age. The age group we are focusing on for our conversation today are patients age 18 to 26. Depending on the health system or a clinical issue, these patients can be cared for by pediatric or adult clinicians or both. And within this age group, patients are often transitioning from pediatric to adult providers and settings. Patients, their families, and clinicians may be new to this level of patient independence, and the availability of medical providers can be limited by licensing or credentialing requirements. Depending on the institution and its guidelines for admission to the pediatric service, adult or pediatric providers might work limitedly with this group and be unfamiliar with the ethical issues that arise. Consequently, ethical concerns can evolve as care shifts across these settings. And although this shift is commonplace, little is actually reported about the specific ethical issues encountered in this age group and whether they differ depending on if care is provided in the adult or pediatric setting. In the current literature for the age group in question, 18 to 26, this group is not specifically analyzed. All the studies that I came across in a literature review included patients up to 21 or 22 years of age at a maximum. However, the American Academy of Pediatrics, which I'll refer to hereafter as the AAP, in a 2017 policy statement stated that the upper age limit of adolescence and young adulthood varies based on the individual patient, and that the establishment of an arbitrary age limit should be discouraged. This actually counters past statements made by the U.S. Food and Drug Administration, which identifies the upper age limit of pediatrics, specifically the adolescent stage, as 21 years of age. In 1988, the AAP also set the same age limit for children, with exceptions for those with special healthcare needs. But based on research between 2012 and 2017, after they had previously reaffirmed this upper age limit of 21 years of age, the AAP changed its stance, and they now state that the age of transition to adult care is unique and should not be absolute at age 21 years. In this statement, the AAP gives no specific age and writes that, and I quote, "The decision to continue care with a pediatrician or pediatric medical or surgical subspecialist should be made solely by the patient and family when appropriate, and the physician, and must take into account the physical and psychosocial needs of the patient and the abilities of the pediatric provider to meet these needs." In general practice, though, at CS Mott Children's Hospital, children up to age 21 years of age are admitted, though there tends to be some exceptions. I would also like to briefly touch on the ethics process at Michigan Medicine for those that are less familiar, and Hannah also mentioned some of the ways that you can engage with the ethics service here. Any member of the medical team, including the patients or their family members, can involve the ethics service. For those on the medical team, they can page the ethicist on call from the drop-down menu on the paging website, and you can report an ethics concern either by name or anonymously. During the day, from Monday through Friday, we have our primary ethicist, Dr. Fern, and pre-doctoral ethics fellows on call. Dr. Fern sits on both the pediatric and adult committees, while the after-hours ethicist committee membership varies. This after-hours ethicist is on call beginning after 5 p.m. Monday through Friday and on the weekends. And overall, there is 24/7 availability for any ethics need. The committees then meet monthly and separately to discuss their respective cases. It was actually from one of these discussions in the spring of 2021 that the idea for this project originated. So for this research project, we had two questions we wanted to answer. The first being, what are the primary ethical and contextual issues overall for patients aged 18 to 26 years of age when ethics is consulted by the clinical team? The second question was, how do the ethical and contextual issues differ when ethics is consulted by the clinical team in the adult versus the pediatric setting? To answer these questions, we conducted a retrospective review of 613 ethics consultation notes, identifying patients aged 18 to 26 years of age seen by the ethics committees from January 1st, 2016 to December 31st, 2020. The upper age limit for our patient population was selected based on the fluctuations in the age limit for pediatric care at Mott. This limit was later supported by a policy statement from the AAP on insurance coverage policy benefits for patients up to 26 years of age, seemingly indicating then that patients up to this age of 26 are considered within their scope of practice. For patients meeting inclusion criteria, we collected, besides age, information on sex, race, ethnicity, religion, and location of the patient at the time of consult, whether that was inpatient or outpatient. The notes associated with these patients were then coded using a classification schema for ethics consultation that is adapted from 2 different articles, one of which was mentioned by Hannah as well, the Nilsson et article from 2008, and an additional code book from Johnson et al. In 2019. This slide contains a table with demographic information of included patients. A total of 46 notes were included, 14 pediatric and 32 adult. However, there were only 43 unique patients. The younger patients within our age group of 18 to 26, so that group being then 18 to 20, were seen more often in the pediatric hospital, while the older patients, ages 24 to 26, were seen more frequently as anticipated in the adult hospital. Overall, we had fewer consults in the pediatric setting, which actually aligns with current literature. Of our 43 unique patients, 65% were white, 96% non-Hispanic, and 78% inpatient. Though not noted in the table, all patients spoke English. On the right-hand side of this slide, there is a table with the ethical issues analyzed and the number of times and percentages that these issues occurred. The primary ethical issue in the adult setting was refusal of recommended treatment, while the leading ethical issue for the pediatric setting involved goals of care. Of the 24 ethical issues in the code book we used as a reference guide, only 13 were applicable, and those 13 are listed in this table. An example of refusal of recommended treatment for a patient age 18 to 26 was whether they had the decision-making capacity to leave the emergency department against medical advice. An example of the ethical issue involving goals of care in the pediatric setting was for a patient with severe psychosocial distress who was being transferred to the adult setting. Interestingly, for this second patient example, they were 25 years old at the time of consult in 2016. The suggested plan for the patient was to reintroduce a palliative care consult to support him and have this transition happen. Based on the 2017 AA policy statement, though, that I've mentioned previously, this patient, were the situation to occur again, might not have been transferred due to medical needs being able to be continued to be met by pediatric providers, especially given that this patient's prognosis was relatively guarded. And I quote from the note that eventually there will probably be an admission similar to this one when the patient will succumb to his diseases. Before the transition could happen to the adult setting, the patient's clinical status had actually declined rapidly, and he was sent home with hospice care. He died within 13 days of this ethics consult and 4 days after discharge. This example serves to illustrate possible missed opportunities and transitioning care for this age group at the systems level, and decreasing the moral distress of both providers and patients in this process. On the right-hand side of the screen again, there is a table with the number of times and percentages that various contextual issues occurred. 9 different contextual issues were noted across the 46 notes using our designated code book. The principal contextual issue in the adult setting was communication conflict between the staff and the patient, while the dominant contextual issue in the pediatric setting was tied between communication conflicts between the staff and family and quality of life. For the pediatric setting, current literature heavily emphasizes the triad of healthcare for these patients, which includes the patient themselves, their family if applicable, and the provider. We can see based on this data how these conflicts shift within the triad as the patient gains experience in exercising their autonomy. The conflict moves from the family and staff in the pediatric setting to the patient and staff in the adult setting. The ethical dilemmas and related contextual features experienced by this population are different based on setting. Though the communication dispute for the adult setting was between the patient and the staff, and the dispute for the pediatric setting was between the family and the staff, the contextual issues primarily focused on communication challenges. Part of these challenges may be the result of a lack of focus on developmental milestones and the formation of the self and one's values in the adult versus the pediatric setting, where it tends to be more emphasized. And targeting interventions towards improved patient-provider communication and having adult providers learn more about these developmental stages may ameliorate some of these challenges. Also, we may need to reevaluate our processes for the transition of care from pediatric to adult spaces to see how we can better support the values formation and health literacy of these younger patients. Likewise, prognostic uncertainty, particularly challenging for pediatric providers and also unnerving, may be contributing to the disagreement on the goals of care and assessment of quality of life seen in the pediatric setting. A question to consider might be whether this is an element of ageism, given that we did not see this nearly as often in the adult setting, which is most likely due to a reflection of society's values on medical practice. Additionally, certain demographics, such as age, language, race, and location of the patient at the time of consult from this study, raise concerns for the use or lack thereof of ethics services for some patients. We saw only English-speaking patients, and patients on the ends of the spectrum of this age group receive more consults, leaving our patients aged 21 to 23 potentially underserved. Moreover, predominantly white and non-Hispanic patients were seen. Thus, how we educate patients and their families on the availability of the ethics service that they can request can be improved. Additionally, more information provided to healthcare professionals on this service, as well as continued training and social justice advocacy, is likely needed. Of note, Michigan Medicine recently launched the Health Equity Consultation Service to support patients whose receipt of healthcare may be impacted by prejudice, discrimination, and racism. Thus, the increased promotion and use of that service may affect future research on this particular age group and its demographics. Before moving into a conversation about what the ethics service can consider doing based on this data, I want to address several of the limitations of this study. First, we conducted a retrospective review, which has certain limitations based on the type of analysis, which includes relying on others for accurate record keeping and potential biases influencing documentation. Moreover, the ethical and contextual issues may not have been fully conveyed in the notes. Additionally, this research was conducted at a single center in the Midwest with a robust ethics center that conducts proactive ethics rounds in inpatient settings, which may influence the use of the ethics service as a whole across the institution and explain why we had more inpatient than outpatient consults. Another limitation is that our notes used to obtain the ethical and contextual issues do not systematically list the contextual issues in question. The current format of the note only includes the ethical issue as a distinct section, so we had to extract the contextual issues based on this description provided in the note. Additionally, the coding lexicon we employed is not a standard of practice in coding ethics consults, indicating a greater limitation of this type of research in general, because there is no standard code book used to classify notes across ethics consultation studies from center to center. So to inform changes made by the ethics service in response to this data, we can consider further standardizing ethics consult documentation. Additionally, there continues to be confusion and resistance to the age limit specified in hospital guidelines for patients in the pediatric hospital. So further clarification on our approach to this population is likely warranted. We should also consider elucidating the processes for supporting the transition of care to the adult hospital and how information is exchanged across these settings. I'd be curious to learn from audience members at the end of today's ground rounds about Michigan Medicine resources on and experiences with this transition, and why we might be seeing the gap in consults for patients aged 21 to 23 in our data set. Thank you all for your time and attention, and please feel free to contact me at lionsam@umich.edu.
Great, thank you, Sam. All right, we're going to transition to our next presenter. Yana's going to present And then we'll have time for questions. So please keep them coming in the question and answer section, and we'll address them at the end.
Sorry, I was muted. All right. Hi, my name is Yenna. I'm an M4, currently on a research year, and today I'll be speaking to you about the clinical ethics consultation that we see within the incarcerated population at Michigan Medicine. I have no relevant disclosures. So to provide you a little bit of an overview, I'll start with a background of mass incarceration in both the United States and in Michigan, and then I'll go over some clinical ethics concerns that are seen in correctional health. I'll then move on to our incarcerated population at Michigan Medicine specifically, then wrap up with our conclusions. So when we think about mass incarceration as a whole, we often just think of prisons and then jails. And while that is somewhat true, it's a lot more complicated in the United States. In the US, we have thousands of facilities that are composed of local jails, state prisons, federal prisons, immigration detention centers, Indian county jails, juvenile detentions, and all of this is still not including military prisons, civil commitment centers, or prisons in other US territories. Altogether, these facilities house roughly 2 million people in the United States. So the United States is known to have the highest incarceration rate in the world. We are only followed by Rwanda, Turkmenistan, El Salvador, and Cuba. Our rates are so high that 1 out of 5 incarcerated people in the world will be incarcerated in the United States. But if we further stratify the incarceration rate by states, 24 states, so nearly half, have higher incarceration rates than the national average. Racial disparities in mass incarceration have also been very well documented and demonstrates that minority individuals are more impacted by incarceration than white individuals. The percentage of Black Americans in the general US population is only 13%, but they make up 38% of the people in prison or jail. The incarceration rate for white Americans is around 450, while for Black Americans, it's over 2,000. The racial disparity is consistent, even if you divide the data up by gender. Whether it's in the men's prisons or the women's prisons, Black and Hispanic individuals are consistently having higher rates of incarceration than white individuals. So all of that was the US as a whole. And now let's look at Michigan. Michigan is considered more progressive with incarceration rates that are well below the national average, but we still have rates of more than double that of our closest international allies. When we look at the racial disparities that exist, in Michigan, it's very significant. Michigan actually incarcerates more Black individuals than anyone else in the country. And while, and while Black individuals only make up 14% of Michigan's population, they're almost 50% of the prison population. And white individuals are severely underrepresented in prisons comparatively. All this to say, mass incarceration is very pervasive, and it's almost guaranteed that healthcare professionals will encounter an incarcerated individual, someone who's been previously incarcerated, or someone that's been impacted by incarceration. Providing care for these patients has always been difficult, largely due to some historical legal barriers. This starts with the 8th Amendment, which stated that there should be no cruel or unusual punishment inflicted. However, this wasn't really enforced. In fact, the Virginia Supreme Court of Appeals in 1871 essentially equated a prisoner to a slave, really stripping them of a lot of their rights and their autonomy. The big landmark case that really helped these individuals access healthcare was Estelle versus Gamble in 1976. To give you a brief summary, Gamble was working on a Texas prison farm when a 600-pound bale of hay fell and injured his back. He ended up suing the Texas's chief prison doctor, the warden, and Estelle, who was the director of the State Department of Corrections at the time. He was suing them for lack of adequate medical treatment, as he wasn't really seen by a physician, for denying him a work excuse, and also for punishing him for refusing to work when he was medically unfit, as they put him in solitary confinement. The US District Court dismissed the case, actually, for failure to state a claim under the 8th Amendment, but luckily it was appealed all the way up to the US Supreme Court. and this was the big ruling. They ruled that deliberate indifference by prison personnel to a prisoner's serious injury or illness constitutes cruel and unusual punishment. This was the first time that the incarcerated population was guaranteed healthcare as a right, and this was less than 50 years ago. As a result, they now had the right to access care, the right to have their care ordered, and the right to professional medical judgment. In more recent years, as you can see on the left, the incarceration rate has been decreasing. However, if you look closer at what happened, the biggest decrease happened in 2020. And from early 2020 to 2021, the number of individuals in custody decreased by more than 16%. But what happened in 2020 was the pandemic. This drop was likely due to delays in processing and data reporting issues rather than systemic policy change during this time, as since then, our incarceration rates has been steadily increasing again towards the pre-pandemic rates. And despite the initial hopes that leaders would respond to the pandemic by releasing people to help decrease the spread of COVID in these facilities, on the whole, prisons released almost no one. The response of the governments was actually so bad that in total, roughly 10% fewer people were released from prisons and jails in 2020 than in 2019. It'd be interesting to see how the pandemic impacts the prison rates, but also the ethical issues that these individuals faced at the time. There are many ethical issues that impact this population, and I'll briefly discuss the ones that are more commonly addressed in the literature. So first is shackling. This would be balancing the benefit of keeping individuals safe, whether that be the patient or clinician, but there are limitations like the patient having the inability to break falls while ambulating, or difficulty positioning during seizure management, or reduced mobility increasing the risk of thrombosis. Another common area of concern is disclosing discharge. This is balancing maintaining security concerns that the correctional officers may have as the individual might plan an escape around their discharge, but this is at odds with patient-informed discharge planning and limits their autonomy severely. Another area is patient privacy. Interestingly, the initial HIPAA proposal actually had excluded inmates, but that was ultimately eliminated from the final regulation because there were concerns that unprotected health information could trigger assaults within correctional facilities on those individuals that had stigmatized conditions. But the exception for inmates are that the hospital may disclose personal health information to a correctional institution or the official maintaining custody. And lastly, the most documented issue is surrogacy. This is largely due to the fact that we need permission from the warden or official to contact a surrogate, even if they have one. And sometimes the warden isn't available, like on the weekend. If one couldn't be found in the past, prison officials or treating physicians have acted as surrogates, both of which obviously have conflicts of interest. So while the literature really encourages the involvement of ethics committees in these discussions, there is really not that much known about it specifically. So we sought to evaluate the frequency and the nature of ethics consultations of inmates at Michigan Medicine. This was the first empirical study really to characterize the types of issues that ethicists are involved in within this population. So we looked at 946 ethics consults to both the adult and pediatric ethics committees from January of 2015 to June of 2022. We identified 39 patients that were impacted by incarceration, the majority being adults. There were 3 consult notes that did not have a medical record number, so they're going to be excluded from the demographic information I'll share with you today, but we were still able to assess the ethical issues that were present in these cases. So I said impacted by incarceration. These individuals fell into these 3 big categories. 41% were currently incarcerated, the majority of these individuals being adults. 26% were formerly incarcerated, 100% of these individuals being adults. And when the surrogate decision maker or caregiver was incarcerated, it was 33%, and the majority were pediatric patients. Looking at demographic information, at Michigan, the majority of the ethics consults were seen for male patients, and the racial distribution was 55% white, followed by 25% Black. Of note, 17% did not have a race reported. Looking at where the patient received care, the patients were largely seen in either the general floor or the critical care unit, rarely being seen in the outpatient setting. And we also tried to look at some other teams that were consulted, as these tend to be very complex patients. So psychiatry was consulted 20% of the time, palliative care 17%, and social work 66%. We looked at the primary ethical issues that were listed here, as well as the primary contextual issues that is from an existing classification schema. So what we found is for the primary ethical issues, about 40% of the time, so the majority, was surrogate decision-making in the adult population. The next most commonly seen ethical issue was beneficence, which was seen about 20% of the time. For pediatrics, there was no ethical issue that was more prevalent than others, likely because we had such a small N. To give you an example of some surrogate issues that was presented in these notes, it was often the inability to reach out to wardens or court-appointed legal guardians on the weekends, or even that the surrogates that were identified were unfamiliar with or unable to speak about the patient's wishes because they were isolated from them for such a long time. And sometimes there was no identified surrogate decision maker at all. When we refer to beneficence, this would include cases where the team would identify an optimally medically preferable plan, but there was system barriers that really prevented them from implementing it. So for example, in the adult population, it was not being able to continue a hyperlipidemia or an anti-seizure medication because the facility that they were housed in couldn't manage IV administration. When we look at the primary contextual issues, obviously all the patients had legal issues as a contextual feature, but the most frequently seen issue was intra-family communication. In adults, this was seen roughly 40% of the time, while for pediatrics, it was seen 70% of the time. An example of each, so for the adult case, it was often that the family member was incarcerated or was estranged from the family due to their incarceration, which impacted the communication between them. In pediatrics, it was a little more complicated, such as when the parent was incarcerated but retained decision-making authority. And there was even a case where there was a dispute between the foster family and the incarcerated biological parents who still had decision-making authority. So overall, our conclusions were that ethics consults regarding incarcerated patients only made up about 4% of all the consults that we saw. This might indicate that clinicians may not be aware of the best ways to utilize ethicists for this population, or they might be unaware of the ethical issues that they should be looking out for. We also saw that over 50% of the patients that received ethics consults were white. And given the known statistics regarding race distribution, especially in Michigan, this raises the question that if we are further marginalizing an already vulnerable patient population. But we cannot make any definitive conclusions, obviously. We would have to look through the EMR to see if there were any cases where an ethics consult should have been placed but wasn't, and if there were any racial disparities there. And lastly, that surrogate decision-making is the most commonly reported ethical concern in this population. This is really in line with the literature, as there are a lot of threats to patient autonomy for these individuals. Incarcerated individuals are rarely offered the opportunity to complete advanced care planning, and they're isolated from their family and friends, so it's not always guaranteed that the surrogate would know what the patient's wishes are. So how can we improve? We can be proactive. So regarding the advanced care planning, maybe we can, as soon as they're admitted, reach out to potential decision makers and keep the warden in the loop. When we try to identify barriers of care, we can try to identify what the problems might be during transport between facilities or any potential limitations that they might have in the facilities themselves. We can improve the education of healthcare professionals. We can make sure that the professionals are familiar with incarcerated individuals' right to advanced care planning and really encourage this conversation, even if it is difficult, especially with the presence of guards. We can also try to include correctional health earlier on in medical education. I'm trying right now, as I'm currently piloting a curriculum in both the preclinical and branches years for students to explore this realm. And lastly, overall, just to encourage collaboration broadly to help improve the quality of care for incarcerated patients. These are my references. Thank you so much for your time today. I'd like to thank Dr. Fern for being an amazing mentor and supporting me in my interest looking into this population.
Great, thank you. I'm going to ask all the panelists to have their cameras on for question and answer. Really appreciate and I've enjoyed working with each of you as well. All right, so we've got a number of questions in the chat. Hannah, I think the first one was for you, just to have, would you mind going through in a little bit more detail, some of the age breakdown for the outpatient population? And while you're working, you don't have to share your slide, but while you're working on that.
Surely. So
Yeah, go ahead.
we hadn't done an in-depth breakdown of the data, so I didn't feel what I had available to me was very helpful, but I can read to you what we have so far. So 3 of the patients out of 48 were under 1 year of age at the time of consult. 39, so the majority of them were between 1 and 18, and 5 of them were over age 18, with 1 patient having an unreported age. I think it'll be more helpful once we break down that larger age group in which most pediatric patients fall from 1 to 18.
Great, thanks, Hannah. So analysis is ongoing, is what I'm hearing. And we hope to do something similar for the adult outpatients as well, to get a better sense of who's accessing ethics consults and where education might be needed, and identify additional barriers that we can hopefully address so that more people have access to the services.
Absolutely.
Right. And then just, I guess, a question for I'm both for Sammy and Hannah, as we're looking at the data that we have. Do you get a sense for how many of the patients have a disability or chronic health condition versus might be in that, it sounds like, that more general pediatrics side of things?
So I could start. This wasn't something we explicitly collected data on, at least yet, but it's a great idea for the future. I would say from my general sense of the data, having read all of these consults, I would say it's most of these patients have some sort of disability or chronic health condition. A lot of these consults were coming from people who have frequent and sort of intense contact with the health system.
And I would echo what Anna has said, Dr. Nelson. I think that would be a great thing, especially for our particular project for the liminal space, because so many of those patients are seen by pediatric providers for chronic illnesses long-term, that it would be helpful to note that. And I think that would be actually a great clarification that we can add as we work to actually write up the data that we've collected into a manuscript. And then to your comment also about the health equity consultation service involving ableism, I know that the consultation service addresses all forms of prejudice and discrimination, and that they continue to work on addressing all the isms that can impact patient care. And I do agree with your statement as well, that there are many instances at times where health care providers think the quality of life for folks with disabilities is lower compared to others. And I think overall that is a systems level change that is occurring through multiple different platforms. Most recently, we had all received an email about the Anti-Racism Oversight Committee, which includes many other aspects of discrimination and prejudice besides racism.
Great, thanks, Sammy. I think to that comment as well, one of the questions thoughts I have about why goals of care is a prevalent concern. And as we coded it, it includes things about, uncertainty around prognosis, disagreement around prognosis, and for goals. And I think it's also, it was often overlapping with the contextual feature of quality of life. And so I think just different perspectives about what quality of life is and what would be acceptable might be contributing that too. So I think that's worth more exploration as well. All right, I'm looking through other questions. There's some questions about how the data that you all presented compares to general patient population in Michigan, or Michigan more at large, if we're thinking about how we may be impacting minority groups or in different ways in access concerns.
I addressed this briefly in a typed answer to one of the attendees. Thank you for that question, because I think it's very insightful into the data that we were presenting. And so actually, based on census data for the state of Michigan in 2022, the demographics, at least for my data set, were quite similar to the state demographics. It was 79% of the state identifying as white and 14.1% identifying as Black. And we had somewhat close percentages there for our particular research. But for that census data, is those who participate in the census, so we might be missing other patients as well. And then that also does not necessarily directly correlate with the demographics of the patient population we have at Michigan Medicine. But I do not know those patient demographics, so they could actually line up well with what we were seeing in our data set. But we do know that bias affects care. And so with the growth of the number of consults that are being seen by the Health Equity Service, we are potentially missing patient cases that would have benefited from an ethics consult prior to that service's development this past summer.
I think that we did, Hannah mentioned a study that we did on the inpatient side where we actually drew the census data for that specific time period, and then did compare consults, and it was it seemed like acuity of illness when we controlled for things including race. It was acuity of medical need that raised an ethical, seemed to be correlated with ethics concerns rather than race, because we do have concerns for whether or not bias is influencing ethics consultation there. But I think ongoing exploration related to the data that we've pulled for these studies to make sure that how that does or does not align with patient population is important. All right, I have a question regarding just a clarification regarding deliberate indifference for health incarcerated people versus negligence, and that there's a higher standard of evidence for deliberate indifference. And so I think the challenge then is how can medical ethicists work to ensure that we support patients' medical needs and appropriate document communication to carceral officials to support potential future claims of deliberate indifference. I think that is a big question. I think being thoughtful about our documentation is a necessity for all of our cases. Again, I don't know if you have more thoughts, because Deanna and I have been talking about recent cases, including some of the Supreme Court decisions from earlier this year and their impact on prisoner and incarcerated rights.
So that's the big thing. It is definitely more difficult to get deliberate indifference rather than negligence. But there was actually a recent case in 2022, the Shin versus Ramirez, that basically said that these inmates can't bring up newly found information that wasn't presented in the state level to the appeals, for the Supreme Court or something like that. So even if we ended up figuring out something because they didn't get care at this point, this could have been prevented, et cetera, if that wasn't presented earlier on in their trials, then it can't be presented at all. So it's just getting more and more difficult for these people to get care and overall just get representation and support to improve their care.
Great. And we have ongoing questions, but I do know we're running near the end of time. So please, we'd be happy to contact and address any of the unanswered questions that are remaining. We really appreciate everyone's participation, and thank you to the panelists for their presentations. We hope everyone has a safe rest of the day and stays warm, and good luck for all those parents who are parenting their children at home today. All right. Thank you, everyone, and we'll see you next month for our next bioethics grand rounds.